explained very well. And all the doubts, everything will be clarified later on. And we'll move on to the next talk. And Dr. Subudhi is also available with us for the conduct of this session.
Good morning to all of you. So now I welcome Dr. Nishitha. She's from Calicut Medical College. Yeah. So simply speaking on the bleeding eye, it's a very common thing we come across in our day-to-day practice, and when and how to intervene in hyphema. So it's over to Dr. Nishitha. Next couple of minutes yours.
So good morning everyone. I'll be speaking to you on hyphema, when and how to intervene. So as you all know, hyphema is the blood collection in anterior chamber, the most common cause being blunt trauma to the eye. The incidence is 12 per 1 lakh population per year, and the most common age group affected is 10 to 20 years. 80% of those injured are males. These are the common etiologies which result in hyphema. Pathophysiology, the mechanism of injury, there is blunt trauma resulting in anteroposterior compression of the eye with equatorial scleral expansion and limbal stretching with posterior displacement of the iris lens diaphragm. So there is a shearing force over the iris, ciliary body and trabecular meshwork resulting in tearing of the vessels and hyphema. Hyphema can be graded depending upon the amount of blood present in the anterior chamber. Grade 1, when the blood is less than 1/3 of the anterior chamber. Grade 2, blood occupying 1/3 to half of the anterior chamber. Grade 3, half to near total, and grade 4 is total. Then you have the micro hyphema, in which there is no layering of blood but circulating RBCs are seen. Various blood tests may be done to rule out any bleeding disorders, and CT of the orbit may be done to rule out intraocular foreign body, open globe injury and orbital fractures when suspected. The treatment of hyphema is aimed at reducing the rebleeding rate, clearing hyphema, treating the associated lesions and minimizing the long-term sequelae. The treatment consists of supportive management, medical intervention and surgical intervention. The supportive care consists of rest with moderate activity to prevent rebleeding, head and elevation for the hyphema to settle, and use of eye shield to protect the eyes. The medical intervention consists of pain relief using opioid analgesics and oral acetaminophen. Avoid the use of NSAIDs and aspirin. Cycloplegics like atropine 1% eye ointment is used twice daily, stabilizes the blood aqueous barrier, increases the patient comfort and facilitates posterior segment evaluation. Miotics are preferably avoided. Corticosteroids, prednisolone 1% eye drops is used 4 times daily to decrease the traumatic iritis associated with hyphema. Systemic steroid, oral prednisolone 40 mg per day in divided doses is found to reduce rebleeding. Antifibrinolytic agents like aminocaproic acid and tranexamic acid is found to be effective to decrease the rebleeding. The mechanism of action is they slow the clot lysis and reduces rebleeding. The contraindication for use include intravascular coagulation disorder, pregnancy, cardiac, liver and kidney disease. They have to be used for a minimum of 5 days because early cessation of treatment will result in rebleeding, rapid clot lysis and rebleeding. The newer medical agents include fibrinolytic agents, that is a recombinant tissue plasminogen activator, is helpful in stagnant clots. 10 micrograms given as intracameral injection is found to resolve the hyphema in 24 to 48 hours. Then transcorneal oxygen therapy is useful especially in patients with sickle cell disease. Humidified oxygen is given at a flow rate of 1 to 3 liters per minute is found to reduce the IOP rapidly in patients associated with sickle cell hyphema. All patients with hyphema should be followed up for the size of the hyphema, the intraocular pressure and corneal blood staining. And most of the hyphema will resolve in 4 to 7 days without any sequelae. Surgical intervention is required only in 5% of the cases. And indications include IOP elevation not responding to medical treatment and corneal blood staining. IOP rise is primarily due to the trabecular meshwork outflow, obstruction due to RBCs, inflammatory cells and the debris, also due to pupillary block caused by large clots. The increased IOP will result in transient ischemia to the optic nerve head, resulting in pallor of the optic nerve head and optic atrophy. The corneal blood staining is due to hemosiderin deposits in the cornea. And it is a definite indication for surgical intervention in the embryogenic pediatric age group. Because it starts in the center and clears last in the center, the visual recovery will take about months to years. And in pediatric age group, it can result in stimulus deprivation amblyopia. So an early recognition of this corneal blood staining is important in pediatric age group, and it is an indication for surgical intervention. The sign include straw yellow discoloration of the deep stroma and tiny yellow granules in the posterior stroma with loss of normal fibrillar structure. And when to surgically intervene? To avoid optic atrophy, IOP elevation, surgical intervention is indicated when there is an IOP elevation of more than 60 millimeter mercury for 2 days, IOP elevation of more than 50 millimeters of mercury for 5 days, and IOP elevation of more than 35 millimeters of mercury for 7 days. To avoid corneal blood staining, surgical intervention is recommended when IOP elevation of more than 25 millimeters of mercury for 5 days is present, in case of near total and total hyphemas. To avoid peripheral anterior synechia formation, any hyphemas failing to resolve to less than 50% of the volume of anterior chamber within 8 days has to be surgically intervened. And any case of pre-existing glaucoma needs early surgical intervention. Special mention on sickle cell disease, because in them a mild and short-lived IOP elevations can result in optic atrophy and cause decreased vision. So in sickle cell disease, an IOP elevation of more than 25 millimeters of mercury lasting for more than 24 hours, or a repeated spike in IOP of more than 30 millimeters daily for 2 to 4 days is an indication for surgical intervention. Now, how to intervene surgically in a case of hyphema? There are different techniques. The AC washout, clot removal via vitrectomy, IA instrumentation, and trabeculectomy. AC washout and clot removal, 2 paracentesis ports are made. Through one, irrigation is done, and through other port, the posterior lip is depressed so that free flow of liquid blood occurs. It is the simplest and the safest method. The remaining clot can be removed with the help of irrigation cannula. Clot removal with vitrectomy instrumentation. Anterior vitrectomy cutter is used to cut and aspirate the clot. Through one port, irrigation is done, and through the other port, vitrectomy probe is used to cut and aspirate the clot. The cutting care should be taken so that the cutting surface do not face the iris and lens in order to avoid injury to these structures. And this requires considerable experience and expertise. Trabeculectomy is indicated in patients with massive hyphemas associated with tremendous IOP elevation. It is combined with AC wash. It results in immediate reduction of IOP, but the long-term results are limited. Iridectomy helps to remove the pupillary block. The newer surgical, more and more phacosurgeons are resorting to ultrasonic emulsification of the clot, but extreme care has to be taken to avoid injury to the normal lens because it can result in cataract. So with this, I come to the end of my presentation. Thank you all for your patient listening.
Thank you, Dr. Nishitha, finishing the time. So I think any discussion we can go after, but one comment I would like to say, you said that the hyphema is more common in males, but I doubt now, because females are now very much active. I don't know, it's equal in both sexes, so it's not, sex is not the common, I know. So thank you. I think any discussion regarding this we will discuss later. After this session, I mean, that is all the present